Hi and welcome back. If you've watched the first video in the series, you've just covered a review of the basic views. As a reminder, we're now going to talk again about pathology. Specifically, we're going to aim to discuss what the abnormals are, what they should look like, and what we're looking for in those views. So let's get to it. First and foremost, thank you to Dr. Adorno, my prior fellow, pictured here, who is now faculty over at Christiana, helping design their sim curriculum. Okay, so as a brief reminder, we talked about the clinical questions for an echo, right? Every single ultrasound we do has a series of yes-no binary questions that we're trying to answer, specifically when done in the point-of-care realm. There are more advanced topics that will do comprehensive echoes. Our goal is to never do one of those, right? Our goal is to simply answer the clinical questions at hand for the patient in front of us and to recognize the limitations of what you're doing compared to a cardiology or radiology performed study, whatever the case might be. So those clinical questions are ejection fraction, effusion, and equality, or looking for our V strain. So as a reminder, ejection fraction is how well the heart is beating. Normal is 45 to 55% depending on which textbook you read. Some will go as high as 60. Pericardial effusion, a small effusion can be normal or physiologic, but you're really looking for something larger, especially one that causes hemodynamic compromise. And then equality, or V strain, is looking to see whether there is right ventricular dysfunction. Specifically, you're usually looking for acute right ventricular dysfunction in the setting of pulmonary embolism. However, there are many things that can cause chronic RV dysfunction. We're going to talk about each of these as we go. As a reminder, we don't need a number on ejection fraction. We are simply looking for a normal, depressed, or hyperdynamic. All right, let's start by talking ejection fraction. There's a few different views you can use to look at this. Most people will start off by looking at the parasternal long axis view. When you look at the parasternal long axis view, you're typically, as a reminder of your anatomy, left atrium here, left ventricle here, aortic outflow tract here, RV here. Same thing duplicated here. And what you're expecting to see here is you're looking to see how well those walls are coming together. Those walls should come together pretty strongly, so much so that about 50% of that volume should get pushed out, right? 50 to 60% is considered a normal EF, so roughly half that volume should get obliterated with each systolic beat of the heart. If you look over here, it's pretty obvious that that's not happening. Now, you will hear from some folks, or you may have already heard, about excursion of the mitral valve. That is a reasonable metric to use. However, there's about 20 different exclusions for these, so I recommend against initially looking at that and simply using your eyes to relax and see if that heart is squeezing normally or not. I don't tend to call an ejection fraction on a single view. Usually 2 to 3 views are minimum to get a good idea of what the patient's ejection fraction is. So, as a counter, the parasternal short axis view, which we covered in the previous video, how to get it, you're looking to see if you're getting the strong symmetric contraction in all parts of that myocardium, and you're specifically looking at the level of the papillary muscles. If you end up going a little too proximal, and you end up going closer to the base of the heart, you'd end up getting at the annulus of the valve. The annulus, as a reminder, is fixed. It does not tend to move much, so you'd get an artificially reduced ejection fraction. By that same token, if you end up going far more apical and getting just much more of the actual apex of the heart, that is always hyperdynamic compared to what the true ejection fraction is. Your best indicator of ejection fraction is to be at the level of the papillary muscles and to look for whether you have a strong symmetric squeeze and whether it looks like it's getting rid of about half the space. Same way over here, you can see on this side, you have papillary, and you're really not seeing much contraction there at all. That's a pretty terrible ejection fraction. Moving on, the third view you frequently use to look at ejection fraction is the apical four-chambered view. That's a nice normal ejection fraction. As a brief walkthrough of anatomy again, that's left ventricle, aortic outflow tracts right there. There's your left atrium, right ventricle. And by comparison, contrast how well this left ventricle is moving to this one. And you can see that marked difference between those two. This is another helpful view to look at it. Subxiphoid can also be used, but we're not going to dive into that for the purposes of this video. Next up, pericardial effusion. Okay, so in this case, you're looking to see whether there is or isn't a pericardial effusion. So over here, you can see on the parasternal long axis view. Remember, we talked about how the aorta can be helpful. Your descending thoracic aorta was very helpful at deciding whether you have a effusion that is pericardial or pleural. Because if it is superficial to the aorta, it must be a pericardial effusion. If you have a effusion that is deep to the aorta, so somewhere down in this space, that would be where you'd expect to see a pleural effusion. So on this example here, you can see right ventricle there, left ventricle there, aortic outflow tract, and left atrium. and you see a very large circumferential, because it's in all quadrants around the heart, pericardial effusion. You could even argue that you're likely seeing a little bit of right ventricular diastolic collapse, because as a reminder, in diastole is when the heart tends to be most affected by these, so you're looking for whether in our diastole this is getting affected. We can dive into this in more detail in the small group sessions. The next view you frequently want to use is an apical four-chambered view. On an apical four-chambered view, again, right ventricle here, left ventricle here, left atrium, right atrium. Here, you're seeing right here is your left ventricle, left atrium, right ventricle. And you see this very, very large circumferential pericardial effusion again, and I would argue that you likely have some degree of RV embarrassment from this. We can talk more about all those details in small group sessions as we've discussed. Okay. Next up, the best view to look for pericardial effusion by most textbooks is a subxiphoid view. Now, the subxiphoid view is classically designed for the FAST exam. As a reminder, here you're looking to see the through the liver, you're looking to see if the heart has a collection of fluid around it, with the pericardium being well illuminated, since it's this bright white line right there. On this example here, you see right ventricle there, left ventricle here, right here is your left atrium and your right atrium. And you're seeing that there's this area of anechoic or black space that is around the heart, and then the pericardium seems to be this bright white line here that extends around it. So that's a circumferential pericardial effusion again. Okay. Next thing we're going to talk about is equality. Now this one is a little more challenging. Looking to see whether the RV is larger than the LV is often fraught. The classic description is 0.6 to 1. My general advice is to ignore that and to simply assume that if the RV is as big as the LV, you likely have RV dysfunction. The challenge is telling if that's acute or chronic, which we can talk about in small groups. But here's an anatomy reminder. You have left ventricle here, left atrium here, right atrium here, right ventricle here. On this view, this is right ventricle, left atrium, right atrium. And as you can see, as the heart is beating, you can see that that right ventricle is significantly larger than the left ventricle. If you ever are unsure, the way you'd have to do this is you'd have to measure across the annulus of the mitral and tricuspid valves, and that annulus would tell you whether or not the RV is enlarged. In this case, this right ventricle looks rather enlarged, so that would be suspicious for acute or chronic RV strain. Same way, in one of the other views you can use this parasternal short axis. Now, the point I will make to you is that if you see a normal apical four-chambered view, where truly the right ventricle is smaller than the left ventricle, it is reasonable to say that there's no evidence of right ventricular strain. In the absence of a good apical four-chambered view, I do not think it is appropriate to say that there is no evidence of right ventricular strain, because these other views are specific for pathology, but they're not sensitive. So if you have a normal parasternal short view, you could have an abnormal apical four-chambered view. So on the parasternal short, here's your left ventricle, here's your right ventricle out here. Now this is usually the right ventricular outflow tract, depending on what angle you're at. And usually, your left ventricle is about the size of the right ventricle, and when it beats, you can see that it's pushing into the right ventricle a little bit. As it's a higher pressured system, that's not surprising. But here you can actually see that the septum, the interventricular septum, is getting squished a little bit towards that left ventricle. So the right ventricle seems to be overpowering the left. And this is another example of the same thing. Finally, the other view you can use is your parasternal long axis view, where you're looking to see if the right ventricle, the aortic outflow tract, and the left atrium are roughly the same size. This is here where that's a rather large right ventricle, a reasonable sized aortic outflow tract by comparison, but then the atrium is small. So this would be suggestive of there being some RV dysfunction. I recognize there's a lot of information. If this feels confusing, watch it again. It should make more sense, and then we will do this all in small groups. So if you have questions or concerns, you know how to get a hold of me. Feel free to send me any emails. Thanks.